This is Matthew Budoff. I've been using these I was going to say Singulex markers, but these Viridia diagnostic markers now for a number of years, both in clinical studies as well as in my day-to-day clinical practice. And I just wanted to refresh with you some of the literature, not all of it, but just to go through some of the studies related to the biomarkers of cardiac function in context of the cardiac troponin. So the cardiac troponin, the background is very simply, and we're all familiar with troponin assays, is that there are really three different regulatory proteins. There's troponin C, troponin T, and troponin I. Singulex has focused on cardiac troponin I as the only one that's produced exclusively in the heart. It's released under the normal circumstances with cell turnover, so there's a very small detectable level even in normal patients. But as there's myocyte injury, necrosis, or ischemia, the numbers of cells that are damaged are increased and troponins go up. We've typically used this in the emergency department to detect a large myocardial infarction. But in reality, we could use this routinely in other environments as well. And I'm going to show you where we've used it now in a more stable population to look at the differences across a cohort, different cohorts. So when we look at the thresholds, and this technology provides us with an opportunity now to look at thresholds that have never been seen before. In most situations in our emergency departments, the detection threshold is often much higher than the picogram values that we're able to see with this technology. And this technology allows us to see, on average, 40-fold more higher sensitivity than a lot of our hospital assays. So the values that we're going to be using are picograms, different than what we use in our emergency room settings. And I'll try to make that clear as we go forward. But understand that at the far left here, the healthy myocardium will have a very, very small turnover of cells, and there may even be detectable by this technology. And then as the damage is increasing, as the risk of the myocardium and ischemia is occurring, as the micro necrosis is occurring, there will be an increase in troponin release. And that's going to be something that's both detectable and has very important prognostic and treatment implications. So there are a lot of studies. Fortunately, they asked me to only focus on a few, so we won't be here all day, but I will focus on these 5 studies that I think nicely illustrate the use in primary prevention with both the Minnesota Heart Survey as well as a population that underwent nuclear SPECT scanning. We're going to look at secondary prevention, the Scott Heart trial, and then we're going to look at the how we can use it in treatment management and decide on lipid targets or on drug treatments and how that impacts the troponins over time. So first, the Minnesota Heart Survey, and there have been a lot of these studies. This is just one representative study of the power of this. And you can see that these are asymptomatic patients, about 4,400 people, and they suffered about over 200 cardiovascular deaths. And what you can see is that C-reactive protein on the left was predictive. CRP greater than 3 was predictive of future events, but the hazard ratio was only 1.73. NT-proBNP was about 4 times as predictive. You can see the odds ratio here for CV death was almost 6, a very robust number. And you can see on the far right, the HS, the high sensitivity troponin being most predictive with a hazard ratio of almost 9. This is a remarkable number for a biomarker. I can't stress enough how impressive this is. And this has been reproduced in a number of other asymptomatic cohorts. So the concept here is very simple, that a patient who is, quote, healthy, who has a high HS, high sensitivity troponin, is going to be at markedly increased risk for cardiovascular events. And you can see NT-proBNP also highly predictive and much better than our traditional assays that we've used in this situation, like high sensitivity C-reactive protein. If we look at a population of patients who were referred for MPI SPECT, so this is a population that was to rule out myocardial ischemia, you can see that a high sensitivity troponin cutoff value of just 0.5 picograms ruled out myocardial ischemia with a negative predictive value of 93%. So, and you can see that in the bottom right in the red circle there, you can see the sensitivity, 97%. So in this population, as a rule out, as a sensitive assay to evaluate patients who may not benefit from going on to future SPECT scanning, we could use this test to virtually eliminate the need for further testing with a very high sensitivity and a negative predictive value of 93%. Now, if you notice, as you go up in the Singulex assay, the specificity goes from a very low value, because a lot of patients may have a mildly elevated troponin without having obstructive disease, but by the time you get up to a troponin assay of 3, you can see a specificity climbs to 90%. So you really could use this test as a method to identify those patients who would benefit from further testing, and maybe more important, those patients who don't need to go for further testing. Another impressive trial that demonstrated the benefits of high sensitivity troponin testing is the Scott-Hart trial. For those of you not familiar with Scott-Hart, Scott-Hart was a population of patients. The total study was about 4,000 patients, and it demonstrated that CT angiography was a better diagnostic tool, better prognostic tool than functional imaging. In this sub-study, they took about 1,000 of these patients and said, how well does high sensitivity troponin correlate with obstructive coronary disease on the CT angiogram? And there was a 5-fold increased risk of obstructive disease when you looked at the troponin values. It went from 9% at the very lowest troponin values of having patients with obstructive disease up to almost 50% in those patients with the highest values of high sensitivity troponin. And you can see that for each doubling of the high sensitivity troponin increased the obstructive risk by 1.35-fold. So every time you doubled the value, the risk of obstructive disease increased. It was improving the overall discrimination and calibration of the model to predict obstructive disease. So very much like the nuclear test, we can identify patients who would potentially have a higher risk of having obstruction or a positive SPECT, and in this case, a higher risk of having obstruction by demonstrating a significant blockage on CT angiography. But I think the most important data and the most impressive data that's come out of this concept of troponin testing has been the use of the high sensitivity troponin in patients using the test as a serial marker. So first, just how well does it predict events in a population that's already had cardiac disease, a secondary prevention population, and that's on the left. On the left, you can see that if they had a very low value of HS, high sensitivity troponin, less than 2.9, you can see there was a very low event rate, 1.65% rate of events. And as the tertiles go up, the risk of events went higher. When you get to the highest group, the group that had a value above 9 picograms per ml, the cohort that was looked at with the highest risk, they actually had a 4-fold increase in cardiovascular events as compared to those patients with the lowest measured troponins. So even among patients in secondary prevention, those patients with very high values were at increased risk. And the risk is graded as you go from a very low value of troponin to a moderate value between 2.9 and 5, the risk doubles. As you go from 5 to 9, the risk almost doubles again. So you can see that the risk is graded, and the higher the baseline troponin, the higher the risk of suffering a cardiovascular death or heart failure over the subsequent years. Now, when we look at the curve on the right, this talks to the benefit of therapy and how therapy can be impacted and how that plays a role in event reduction. So I want to start with the blue at the bottom. And the blue at the bottom demonstrates those patients who had a low HS-CRP. And the patients with a low high sensitivity troponin, and the patients who had a low value, regardless of whether they were treated with pravastatin 40 or atorvastatin 80, regardless of randomization to a moderate statin and pravastatin or an aggressive lipid-lowering agent like atorvastatin 80, the event rates were virtually identical. In other words, they have a low troponin. Being on a statin is helpful, but we didn't need to go to higher levels of statin therapy to really affect the benefit. The hazard ratio was 0.88 and the p-value was 0.61, not significant. If we look at the red, though, very remarkable that the patients in red demonstrated a huge benefit. This is a 40% reduction in events. By taking patients who had a high value for high sensitivity troponin above 9 and putting them on atorvastatin 80 as compared to pravastatin 40. For those patients who were prospectively randomized to pravastatin 40, the event rate over the next 2 years was 8%. That event rate dropped by almost half if they were put on atorvastatin 80. And this was a prospective randomized placebo or double-blinded trial where they were randomized to either atorva 80 or prava 40. And those patients with the highest levels of troponin benefited dramatically by being on more aggressive therapy. So I've used this in my practice commonly when I see a patient with a high value for high sensitivity troponin. I can now give them information that and gives me information that makes sure that I treat them aggressively, and I put them on the highest dose of statin therapy to elicit the biggest benefit. There's also data in serial studying in this trial. We don't have the slide here, but it demonstrated that you can reduce the high sensitivity troponin more with the atorvastatin 80 milligrams than with prava 40. So not only do we reduce cardiac events, but we can use the serial troponin assay as a way of following our patients. And those patients where it did not go down, they actually were at the highest risk of events. So the patients who had persistent elevations of serial troponins had the worst outcomes. So seeing that it stays elevated, that's a problem. If it's a high value, we put them on a higher dose of atorvastatin 80, and they do better. The last study I want to review with you is west of Scotland, though the WASCOPS trial. This is just a review of the trial because it's relatively old now, 1995. Unfortunately, I can say I remember this trial being published and coming out, and it was huge news at the time because in a primary prevention population, statin therapy reduced cardiovascular events. Pravastatin, patients randomized to pravastatin 40 had a 31% reduction in cardiovascular death or non-fatal MI. When we look at the patients in context of high sensitivity troponins, we can see that statins, that effect on the troponin was very important to look at the event rates. So a little bit of a complicated slide, and I apologize, this is straight from the publication, but if we look at this quintiles, this is basically saying on the left, patients had an increase in troponin from measure 1 to measure 2. And on the right, they had a decrease in troponin from measure 1 to measure 2. So those people who were decreasing their troponins on the right, whether they were on placebo or pravastatin, their event rates were very low. On the left, those patients where their values of troponin went up over 1 year had big event rates, up almost 12% of patients on placebo had a cardiovascular event in the group that experienced a troponin increase, and statins worked. Pravastatin reduced that rate to 6% with those patients who are increasing, but still a 6% event rate is very high. And if you compare that 6% event rate in quintile 1, those patients where the troponins were increasing, to quintile 5 on placebo, the event rate is 3 times higher. So the bottom line is that there was risk independent of cholesterol lowering, and those patients that had increases in troponins over the course of a year were at a markedly increased risk of events, regardless of whether they were treated with placebo or Pravachol. The overall numbers, the hazard ratio was 2.3-fold, looking at the differences in risk going from the quintile 1 to quintile 5. So patients who had an increase in troponin had a 2.5-fold increased risk of suffering a non-fatal MI or cardiac death over the next 5 years. So again, a beautiful illustration of the concept that if troponins are going down, patients will do better, and looking from blue to red, that patients who are treated with statins who have troponin elevations will do better. So a proof of concept that if patients have high troponins, we want to treat them with a statin. If we go back now to the previous slide real quick, just to reiterate, those patients treated with more aggressive statins like atorvastatin 80 will be at even higher benefits. So we can elevate our statin from 40 milligrams to 80 to get even more event reduction. And we can follow patients serially over time to make sure that they are both a responder, and if they're not responder, we can intensify therapy. So this is just an algorithm that was created. An expert panel created an algorithm to look at what we can do with each condition and how we can potentially treat these patients. And I'm not going to go through the algorithm. This will be made available to you. But you can imagine intensifying medical therapy will be a recurrent theme here for patients who might have sleep apnea. Doing a sleep study and diagnosing their disease and treating them will be beneficial. And certainly adjusting lifestyle risk as well, exercise, medications, and other features that we can adjust to benefit our patients. So I think the simple part of this is if they have a very high troponin assay, especially if they're having chest pain, just like in the emergency room, we would think that could be an acute coronary syndrome. If they're asymptomatic, even with a high troponin assay, we don't need to rush them to the ER. We need to evaluate why their troponin is elevated. And this puts it in context of the underlying condition, whether it's diabetes or obstructive disease or non-ischemic coronary disease, etc., and how we would potentially treat them. So let me finish up my section of this talk with just a quick summary. We can identify early signs of cardiovascular disease. Patients with high sensitivities, troponin above 9 in the Minnesota Heart or above 10 are at the highest risk of cardiovascular death. We can rule out and predict coronary artery disease, so a very low level of high sensitivity troponin ruled out ischemia. And as the troponins increased, the risk of obstructive coronary artery disease was higher. We can manage levels of high-sensitivity troponin to improve outcomes. Patients on statins with the greatest high-sensitivity reduction had the lowest risk for coronary events, and intensifying statins further lowered risk. And I think that's really important as we think about an algorithm for treatment and the need for serial troponin assays.